7 failed businesses. You're still pacing in your house for the next business idea.
Yes.
Where is that fool coming from?
At least 2 out of 4 Ghanaians have a chronic condition. And at UGMC, I was just going around asking questions, talking to doctors, talking to patients. Each person is like a zoo of problems. And everyone's main problem comes to one: medicine. After all the doctor does comes to medicine. People don't know where to find medicine. And when they also know, they can't afford. So the model became very clear: empower access to healthcare, empower the pharmacies, empower the hospital, empower the health insurance, empower the patient, empower everyone within the healthcare space that if you need medicine, you can actually have it. I dropped out of school for 2 reasons.
Wait, university?
Yeah, I dropped out of school. The education system trains pharmacists to become retailers. So they don't know how to talk to a patient. There's no empathy in their line of work. It's transactional. If you walk into a pharmacy, you want to get medication, you will not be interacted. It's just, how much? Wait, where's your money? Okay, take your medicine. And there's no follow-up. Nobody's going to follow up to check on you. But in Upper East, for example, there's no pharmacy particularly.
How? Friends in Accra, the world beyond. I just had a conversation with Mr. Andrew Otchere, and that's the conversation you're about to listen to. And funny enough, I was trying to stall this conversation. I really wasn't in the mood to come to the studio today for us to have this recording. But it's turned out to be a very, very impactful conversation. He's a co-founder and CEO for ReFill. What they essentially do is they are enhancing availability and affordability to medicine, particularly for chronic people. I mean, generally for everybody. And there were a lot of insights he shared from his experience. This is like his 8th business, and I promise you will enjoy this conversation. But then as a community, there is something we've been thinking about, here at the Peswa Podcast. We say that we believe entrepreneurs will build this continent, and we mean that, and we want to throw all our weight behind it. And so in our bid to do that, 2 central things. We want to create entrepreneurial stories and create them as well. So far, the conversation we've been having are just our efforts in our bid to create those stories so you can hear them and take on the journey. And now we want to focus on the part where we actually are involved in creating these stories. And our first item line is you realize from this conversation, we touched on the fact that people who go on to do great things are people who are exposed. And a strand of exposure comes from reading, you see. So we want to introduce to you as a community our book reading club. So what's going to happen is that I'm going to announce a book in our next episode, a book we're going to be reading. And then we give ourselves a timeline to read that book, complete reading that book. We're going to keep ourselves accountable on our socials, here on the podcast. And at the end of the period, we will invite 3 or 4 random people in our community to join me, have a conversation about the book. This is intentional. We know that these things have a way of stirring us up to take on the challenge. Among other things, we're considering doing the Peswa, creating a fund, right, to support small businesses. And we are on the lookout for partners in that regard as well. So we have a lot of exciting things coming up as a community. We're going to build this continent. We're not just a podcast. We're a community of people who are very committed to changing the African narrative, and we will get that done. And so that said, please encourage your friends and your family and yourself, because we realized that about 82% of the people who have watched or listened to our content have not subscribed. So I don't know what you're waiting for. Subscribe, share, because it goes a long way to help us and then the team to keep doing what we're doing. But anyway, as the mantra goes, build something, just build something, and enjoy the conversation. You've built this very important company,
Right.
that is somehow flying low under the radar,
Yeah.
right? And it's very interesting because for one, I really pay attention to the Ghanaian digital tech space a lot, you know. And when Clena mentioned that, oh, there's this company called ReFill, I think we should talk to them. I know the founder. I'm like, what company is that? And I said, okay, let me just check it out. And there's scanty information online, only for me to realize that you guys are really doing impactful work.
Yeah.
He said it's intentional.
Very intentional. I can give you a scenario like, you know, I'm not going to go to how we began and all that, but everything depends on the foundation. What are you building on? What are you standing on? So if it is to make people know what we do, we would have been all over the place.
Yeah.
But that's not the aim.
But you see, the kind of work you do,
Yes.
people have to know what you do to make it more impactful, maybe?
When you're doing it for the first time, you shouldn't start from there.
Okay.
If there was an existing business or existing model like what we have now, would just do billboard ads and of course you just onboard clients and off you go. But when you are the one chartering the course for the first time,
Yeah.
then you have to really get to the ground and dig your head down, keep your head down, keep digging. You need to find your facts, understand the persons you want to serve properly.
Yeah.
And then the channels that really works for them. Otherwise, the biggest problem you'll be faced with is people know about it. Tomorrow, other people copy what you have, launch similar products, and that's it. You lose steam.
Yeah.
So our deliberate effort has been to keep your head down, get the work done. Let's get the trenches, I'll put it that way, well laid out, well dug out, so that when we channel the rivers in, you don't have any hurdles along the way.
Okay. So ReFill is essentially a telepharmacy startup.
So let me give you a
All right.
bit of that. So ReFill is a tech company that focuses on healthcare.
Okay.
So that's why we're a health tech company. Our main focus is empowering access to healthcare.
Okay.
We focus on medication. Access to medication is our key business, and then affordability is our next two.
Okay.
So we come in two fronts: access to
And
medication
affordability.
That's it.
Okay. So how are you tackling the access now?
So access, we started off with working with the traditional pharmacies in town, onboarding all of them, basically. So we work through the community practitioners of pharmacies, we work with the pharmacy council, we work with the young professional pharmacists. All of these are existing institutions that have held down the pharmacy industry for decades in our country.
Okay.
Now, so that's our first step. Get the institutions
Onboarded.
onboarded because the patients are already there anyway. Now, the next thing was to
But what value do you provide for these people, the supply end?
the supply
What's your value for them? What do you tell them?
traffic.
Oh, okay.
Their pain is that they have medicines that's expiring on the daily.
Okay.
Every pharmacist's pain in Ghana today is expiries.
Okay.
Now, if the medicine was being consumed, then they have zero or almost zero expiries. So if a pharmacy sets up 500, usually the regulation allows them to set up 500 meters apart in any area. Now, if a pharmacy sets up, they can't advertise based on the style of industry they are in. Regulatory-wise, they cannot.
Oh, okay.
So no pharmacy is allowed to advertise like that. Now, because of that, what it means is that what they can do best.
Growing up, you used to hear Kina Pharma and all of that on the radio, but how
they advertise specific things like prostate.
Oh.
So they are talking about diseases and what they have created locally that supports.
Okay.
But because in a pharmacy, typically you have many brands. You have Sanofi, you have Pfizer, you have AstraZeneca, you have Roche, you have all of it mixed with the locals and then the generics and then all types of them on their shelves.
Okay.
When a pharmacy puts up a medication on their shelf, they actually don't know who's coming to buy. It's a hope that someone will come and buy. And that's their pain.
Okay.
Now, even though when you go to Kolebu, you have a chain of pharmacies along the road right opposite the hospital. Each time a doctor picked our short code, and actually there's the doctors from those hospitals use our short code, but I'm just by way of speaking. They pass it on to the patient. Why? Because none of those pharmacies along the road still has the medication the doctor has prescribed.
Right.
Because by virtue of infrastructure and supply and demand, they actually can't also stock everything because they do not, even if they are right at the doorstep, but he doesn't know the guy working out of the hospital is coming to look for medicine A or medicine B.
Yeah.
All of them are hoping the guy will buy. So if you go through them, they all have same medications, most of them, hoping that people will buy. Even though the person is just working out of the hospital. Then the person who works out of the hospital goes to each of these pharmacies by the roadside, right in front of the hospital, and none of them has his or her medication. Then you have a patient who is inward, lying on a bed. The hospital does not have the medication. The pharmacist by the roadside, right by the hospital, does not have the medication. Just 2 days ago, we were dealing with some emergency supply for a patient, like a cancer patient. 2 different prescriptions within 2 hours. 1 prescription at a different hour. After almost an hour, another prescription from the same patient. They need this now, else the person is going into some situation. And you ask yourself that, you mean all of these don't have? Yes, out of 6 medications on 1 prescription, this one has 1, but doesn't have the actual dosage. He has another type of dosage.
Yeah.
This one has 1, but he doesn't have the brand or the quantity. So those are the dynamics.
So how are you correcting that?
So by bringing all the pharmacies we have on our marketplace,
Okay.
once we have a prescription, the marketplace is our place to go. All the pharmacies within a region
Okay.
say, yes, I have this, I have. Sometimes 6 pharmacies will respond and say, I have this one, I have this brand, I have near expiry. Would the patient be ready to buy? I can reduce it. Somebody says, I have the actual one, I have the actual dosage, I have the actual quantity, but I can only supply 2 on your list of medications. So it means out of the 6 medications on 1 prescription, you have to get the rest from another set, another pharmacy. But because of how we've run our system, it's easy for all these pharmacies to respond within seconds to say, here. Then by our aggregated system, of course, relying heavily on intelligence. 1, 2, 3, we put them together. Medication is ready to go. Delivery moves from one hub to the other. Pick up medications and send it to the patient.
Oh wow. So you work with like on the delivery side, the logistics, like you work with
So
either
yes,
companies or
so we work with the private couriers. We work with Yango. We work with Bolt. We work with Uber. Then of course the pharmacies also sometimes have their own
delivery system.
Yes.
Nice. How many pharmacy chains have you gone?
So we started off
Pharmacies.
onboarding. We onboarded all 6,800 plus in one sweep from one meeting, of course.
How did that happen?
Well, it's simple but complex. Let me put it this way. So once we laid the fact out there of what their need is, everybody says, sign me up.
Oh, okay.
But of course, it's contractual. So you have to meet certain terms.
Okay.
So if you check our documentations, we will we'll highlight about 470 what we call fulfillment partners. A fulfillment partner, a fulfillment partner meets certain criteria. And for a fulfillment partner pharmacy, what it means is that they have a pharmacist, they have good stock, of course. Some of them even have deliveries, which is a plus if they do, but it's not a requirement. They have good communication skills. They have good customer service. They stick to instructions that we offer them because you need to attach the medication instructions on how to take it.
Okay.
And you must be ready that if a patient needs clarification,
Mm-hmm.
we can rely on you to provide them.
Okay.
Most pharmacies don't have this structure. Very few do. So as we move on with them, as of today, we can confidently say that 470 out of those 6,000 meets that criteria.
Yeah.
But that is also because we are expanding region by region. Today we are in 14 regions. So
Okay. Two
in
more.
those, but I mean, those two, I think in a week, there's a campaign in Upper East that's covering that. So that will be 15, of course. Then, but in Upper East, for instance, there's no pharmacy particularly.
How?
That's the problem. So you have a lot of pharmacies in Accra. 42, from our last data, about 40% of the pharmacies in the country sit in Accra alone. The rest are scattered in over-the-counter type of drugstore and the rest across the country.
So there's no pharmacy in the Upper East region.
There isn't. We're trying to get some people to set up something.
Oh, so you see that their options are just in hospital pharmacies, or
So the pain is even worse when you go to the in-hospital pharmacy. The in-hospital pharmacy also doesn't have the capability to stock. So they have something. They can meet the essential needs of the hospital,
That's very interesting.
but not the need of the guy who has also been prescribed.
What do you think is a holdback? Clearly, there's a market, or is it purchasing power of the people in the Upper
We
East
used
region?
to think it's purchasing power, but what you realize is that if you go to, excuse me, a place like Choco, there's paracetamol for 20 pesos, 50 pesos. Why can't that medicine be up there as well? 50 pesos. There's paracetamol for 100 cedis. It exists.
Yes.
It's also 50 pesos. Basically, what we're seeing is that the persons who are spreading their pharmacy distributions do not consider certain regions. If you go to Ashanti region, for instance, and in our experience, you have Confanoche doctors, they use our shortcut more than the doctors in Accra, typically. They'll tell you, it's not here. The medicine is not here. We don't have it in Kumasi. Because they know almost every pharmacy there. The medicine is not there.
It's in Accra.
It's in Accra. That's what you are dealing with. So it's not just even the distribution per se, but the failure for me, I would say that the failure from our healthcare system so far has not helped to distribute data enough for people who set up pharmacies to know what is in Upper East. If you have persons within that region whose common disease is glaucoma, blindness, medicine in that area, or even specialist hospitals for just that. There are some in Tamale, but driving it across. So the glaucoma patient will need medication. It's a chronic illness.
Yes.
How is the person going to keep up getting medication unless they come to Accra at some point? Because the medicine is short in supply there, or there's no pharmacy. First of all, a drugstore that sells over-the-counter medication cannot sell chronic person's medication.
Because of regulations, I guess.
So even if there's a drugstore there, what they can sell, paracetamol and some few stuff, the rest they can't. So if there's a guy with glaucoma there, how will he or she get medication?
Wow. You see, very impactful business you're running. So now you're tackling the availability problem. You mentioned that another block is the affordability.
Yes.
So now, the availability is still on there. Essentially, what happens is that if you're a patient and your patient is in need of medication,
Right.
they just dial a short code. What's it now?
Star 928, star 100 hash.
Okay, star 928, star 100 hash.
Yeah.
And then I'm sure they're going to dial in.
They just dial. Some people will put in even their names.
Okay.
When you put in your name, we've just activated our virtual assistant. We call it Riva. Riva is ReFill virtual assistant. It's pure AI, natural voice, natural intelligence. It speaks naturally.
Okay.
If a person dials that, even there's a number you can call, or if you dial the short code, it will call you back. Interact with the person. We're moving it. Currently, it's doing English and a few other international languages, but we're moving it to local languages. It's also a test we're doing now, so that if a person cannot speak English, they still need to get medication. You can interact with them in their language.
But is there the option where after dialing the short code, a contact person from your call?
Yes. So once a person does a short code, the next thing is that they get to enter the medication.
Okay.
Some people put in the name of the sickness. They'll tell you that I have pain in my neck. They write it right there. Or they'll say, Isaac, call me. People write us stuff. Somebody will say, my armpit, my neck, my buttocks.
Yeah.
Yes. So our team of pharmacists will call them.
Okay.
In addition to our augmented AI system that does the support to call the person and interact with them and then understand what pain or what is at least happening. And of course, because they're pharmacists, they know that, okay, with this particular situation, you need to go to the hospital.
Okay.
But if you have a prescription for some medication, they'll assist you, take the prescription, serve you through our fulfillment partners and get the medication for the person.
Oh, okay. Wait, were you at the Piazza event?
No, I wasn't.
During the pitch event that day, another company, someone came to pitch something similar.
We heard about it.
Yeah, okay, interesting. Good, because we need solutions like this in our markets. Okay, so on the so that's the availability block. On the affordability, how are you working?
So medication financing is probably the reason why we fall within the low income earning structure in the sub-Saharan African market. Now, what it is that you have different groups. One group is persons who can afford medication, no matter the price. Health insurance augments some of this for some people. But if you've understood our health insurance in Ghana so far, you can tell that the national health insurance has a very, 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 very restricted block where it can't serve certain medications. The Mahama Care, I believe, is stepping in to cater for some aspect of it, which is for chronic persons.
Okay.
But then when you look at medication financing in general, the institutions themselves are lacking one pain. They are lacking one. The persons who need the medication are also lacking in there. So we have the diaspora option where a person can use any of these remittance tools. Currently, we're doing some work with ZPay and Komi, so they are remittance guys, focusing on being able to pay for medication for someone I know. If my friend or my brother or my family member is in the US or UK or Germany, they can easily pay for my medication in Accra or in any part of Ghana for that matter. That's one part. As complex as that bit is, what we've tried to do is to make it easy for the person who is receiving the medication to be able to tell their family member, hey, you don't have to send me money anymore. You can pay for the medicine directly.
Okay.
Because our system has that traceability to show who's paying and who's receiving medicine and whatnot. So there's that bit. Then they have the other part where we have another partner we work with who focuses on actually giving people credit to say hey, your medicine is 600 cedis. I'll pay for you upfront. You have 3 weeks to pay it back. Now, we tried that model with a program we started off with Roche sometime last year. The model was to be able to allow cancer patients to be able to have finance because they need it. So that's the twist you find. Those whose medications are very expensive actually need financing more than the regular person who doesn't even have money to pay for a pain med per se.
Yeah.
So structuring payment models for them allows them to be able to stay on their course. And this is for mainly chronic patients.
Okay.
So during our survey in 2023, one of the patients we interacted with, she's 62. Her average income is about 4,500, but she needs 2,800 every month to cater for medications. Now, the question obviously is, how is this person going to keep up? But she's diagnosed with diabetes, And she had just been diagnosed with glaucoma at the time we met her. So she has 2 comorbidities.
Yeah.
Now, these are different chronic conditions. That's the other twist to what you discover in our system. Persons with one disease usually have 2 or 3 more. So they were initially on one hypertensive medication, but now they have to pay for chronic kidney. And then also maybe acute heart failure, anything related in that regard. So structuring payment plans is what we've been doing so far.
Okay. So essentially, you help people pay for medications flexibly. You don't have to cough up the money up front.
Without, exactly.
With the help of partners like Roche.
So they are also financing persons. So what we have, of course, in 2024, we use that to study what really works, because if a person has a bad credit score, then the credit or financing organization also has a concern. So they want to go through any of the telcos to get the right credit score for the persons on how they pay their loans, XYZ, and all that. But what it is that you can't put a price on health. That's the painful bit.
Yeah.
So as much as you want to get the medication for the person, you need to really understand how their financing is looking.
And that's the problem in our market. You see, I also run a credit-based business, but it's in real estate. And for tenants, so we have to do initial checks on tenants to be sure they can afford to pay. In Accra, in Ghana, you pay rent in bulk.
Yeah.
So we are providing an infrastructure where tenants can pay rent monthly. Now, the bottleneck is that two things. There's a lot of scanty data on people's creditworthiness to know that, okay, this person can afford this, cannot afford it. And then even when you've been able to gather some data to see that, okay, this person can afford to pay, there's also the issue of willingness to pay in our market. You have to, the recollection has to be so firm that it feels like you're choking the person, because it has to be so tight, right? And so giving these like elements of strain in offering credit in our market, how are you navigating that?
So what we've realized is that when a person is not well, they have an obvious feeling that they're about to die. In studying some bit of human psychology in that area, what we've learned is that people do anything to live.
Okay.
So if it means calling friends to pay up, they'll go there.
Okay.
Now, when a person is having a chronic condition, they know then that this will kill the person one day, but they want to live as long as they can. So what does it take? From what we've gathered so far, you have few people defaulting.
Okay.
When it comes to these things. Because every 30 days they need that medication anyway.
So they'll pay before
they have to pay for it.
Yeah.
So if you offer them something, then the person says, hey, and they know that we solve affordability on one part. Let me just chip that in. So what the person would have bought for a monthly cost of this person, let me use this lady X, whose cost is 2,800. Upon meeting with us, she's now spending 1,600 on the medications.
Okay.
How? She forms part of a group of people who are looking for the same medication. So our model allows all our fulfillment partners to say, hey, here, I need it off my shelf.
Numbers, yes.
I need it off my shelf.
So
ReFill, you have the traffic, take the medication and give me the business.
That's interesting.
So, yeah, it's a demand and supply, like I said.
Numbers.
So if you create it right, then you get it.
Cost.
So instead of she paying 2,800, now she's paying less. So therefore, she has some extra. She says, hey.
It's an interesting perspective, because I was just currently thinking that, well, if you're going to be a middleman between suppliers and people who need a supply, there's always going to be a markup, because you have to make money.
Because
commissions.
it's a business.
So, but now that you've explained it this way, it gives me some sense of how well the pricing can reduce and you can still get to make your money as a business.
And we're doing the same for, even the health insurance companies we work with. All of them will tell you that we want good pricing.
Yeah.
Now, a typical health insurance would want to onboard, and they've been doing it till they met us. Of course, two of them said, "Where have you guys been?" And what it is that they have to onboard every pharmacy individually.
Yeah, but now you guys have that. So you just plug in.
Exactly. So if they connect to our APIs, then it's like straight away.
Makes sense.
They have access to now their core business of
pharmacies.
Their core business of insurance is what they do. We do the rest. So it's a health insurance company. They just keep funneling in their prescriptions.
Yeah.
We do the rest. We send back the bill to them. And it's an easy business for them.
Great business, impactful. I know you're 38,
Right.
Very young man, prime of your life. How did it start?
So my business had collapsed a year into 2 years after COVID. And that was like my business number 7, I think.
Wow.
So
What business was that?
tech. I've been in IT business, IT tech, IT consulting business since I left Vodafone in 2013. I used to work with Vodafone.
Yeah.
I was, of course, Ghana Telecom, then Vodafone.
Beautiful.
I left in 2013 and started, of course, before that, I had this side gig, as we always called it. But then I decided to make it my main business. So in 2019, 2020, wasn't due to COVID, but just bad organizational governance. We had to shut down. Now, after the shutdown, then, of course, I still have my 1 or 2 things I do on the side. But then the point is, what are you going to be doing? So I remember one night, I think in 2022, late 2022, October-ish, I was just pacing up and down my house thinking of what next? What next? Because I like to solve problems. I like to be in tune with complex problems that I can dig my hands in. And just about the time I was thinking about what to do. So the next morning, it was a Saturday. The next morning on a Sunday, my co-founder, David, he's a pharmacist. So he sends me a problem out of the blue. I mean, I know him, we're good friends, but not on a Sunday morning. So I look at the problem and I'm like, it's easy. So I started drafting it. So I drafted the solution and I sent it back to him. That's what we can do. And he said, hey, how do you know what we can do? Because
You've been doing it for years.
Well, you are not a healthcare professional. How do you know? So, okay, I've structured something. So when I started putting it, I said, yo, come on. This is it. This is what I've been thinking.
Wow.
Okay. So the problem is pharmacies struggle to keep track of medications for chronic patients. They don't have a system. Even now, they don't have a system that helps them to track, manage, and then process the orders of medications for chronic persons. That's the problem. And it's a whole thing that they were discussing on some platforms. And I said, okay, I'll draft it. So I drafted a solution, put it together. Then I called another friend of mine, Kofi Asuma. I said, I think we can make a business out of this. So I did a skeletal structure of it, business, the solutions. I sent it to him. A week later, he called me and said, okay, we have a dashboard. So I looked at him like, okay, let's get into registration. So 2023, we started registration.
Just 2 years ago.
Yeah. So we just moved. March 2023, we launched the MVP and realized that, okay, here we go. It's selling. It's solving the problem that we thought couldn't be solved so easily. We are managing the patients whose medications were on our system. They get alerts. Back in 1960, also 1940 to 1960, America had a system where they used postcards and phone calls to remind persons about their medications. So they switched off and added Initially, it was just a postcard. They added the phone calls because people were still forgetting to fill in. And the postcard, you have to, when they send it to you, you fill in your refill data and send it back to them. Then the medications are organized. And then they realize that it's working to some level, but it's still cutting out a large group of people. So they added SMS. Now, SMS was supposed to be an easy option where people get SMS alerts about their medications and next. But when the person gets the alert, they need to act on it.
Yeah.
And that's where the problem was ending at. So when we looked at it, we said, okay, we can solve all the reminder problem, but you need the patient engagement. The patient's real pain is that after you've told them they are due for refill, they don't know where to find the medicine. So we launched the next, we pivoted literally to what you now know as Find My Med. That's where the short code came in.
Find My Med, okay.
So the short code was to introduce the interaction, to kick off the next step of the person making the effort that my amlodipine or my X-Forge or this and that is finished. I need a refill. So they started off like that.
Okay.
Then we turned out that the biggest challenge actually was that almost everyone needs to find medicine.
Okay.
So
not
now
just chronic.
not just the chronic people. So we had to open it up.
Okay.
So that's where the short code, we started putting a few billboards and went to radio. And all of that was just testing to see. Mm-hmm. And you could see that thousands of requests coming in, everybody asking for medication all over the country. Then, like, okay, so let's cool down here.
Yeah.
Take all the information you've received. Let's go back to the drawing board. Where is the problem coming from? So that's how we found out that the problem was people don't know where to find medicine. And when they also know, they can't afford.
Yeah.
All right. Then the third problem was that there are not many or enough pharmacies that can actually serve certain medications.
Mm-hmm.
So people are traveling around literally. Somebody will tell them that the medicine is in Accra. Accra is as you know it. Where in Accra?
Yeah.
One friend of mine said that he spent 3 to 4 hours driving through communities in Tema just looking for 2 medications. 4 hours for his sister who was dying. So the point is, can he just dial the short code and put the medicine? And he said, yeah, he just did it. 15 minutes, medication is at her doorstep. 15. Why? There are 2 communities away. That's where the medication is. Just 2 communities away. But how could he have known? He had already driven through 4 to 5 communities.
Yeah.
Because if you're at the junction, do you know you should go left or right? Which pharmacy has the medication? When you get there, they tell you, we don't have the quantity. We don't have the dosage. Or what we have is also near expiry. If a person needs it for 60 days or 30 days, what they have is 15 days expiry. So who has what? Then you have doctors who dial the short code and say, hey, can you guys help us find this medicine? We have a patient about to go to theater. I remember when I saw that particular one, our pharmacist was talking to the doctor on the phone. I laughed because I was like, this is insane. You mean you have a patient about to go to the theater and you are asking us to find you medicine? Say, yes, we have 8 minutes. Wow. Okay, let's do it. So we go ahead. We call the doctor and say, okay, we found the medicine. Who's paying? That's the problem now. Said, can you deliver it? Because the patient is about to die. Deliver. So somebody has to take the risk. So we take the risk, have it delivered, and then the patient survives. I said, okay, here's your cash. We don't do cash. It was a test, basically, for us. So we don't do cash at all. We do all our payments are digital. So you have to also now enable digital payments for people.
Is there a reason why there's no cash?
Yes, because we don't control the courier.
Okay.
So if you want someone to collect the cash, it has to be the courier guy like you have for the food business.
Yeah.
But we don't do that.
Okay.
So that it allows digital payments to work.
Okay. So what happened from that test?
Oh, yes. For that, yes, we had to do cash because one of my colleagues literally had to go there. That's David himself. He went there because the other problem was that the nurses didn't know how to administer that medication. Anyway, so not to dive into all that, but this is how we tested stage by stage what we plan to do.
Okay.
So the model became very clear: empower access to healthcare, empower the pharmacies, empower the hospital, empower the health insurance, empower the patient, empower everyone within the healthcare space that if you need medicine, you can actually have it.
It's a very beautiful story because 7 businesses in, you kept going.
Yeah.
I'll ask you about why. Let me ask you now. What made you think that you had to keep going? Because you had a job with Vodafone, Ghana Telecom. I'm sure you're doing well, and you decided to set out to do something on your own. And 7 failed businesses. You're still pacing in your house for the next business idea.
Yes.
Where is that fuel coming from?
So I think that, I've been exposed to a lot of, I read a lot. So I look out for what I think came to me naturally, I would say, is that there are many people with different problems. Some people can solve some problems. I thought of myself as one. I remember when I was 16, I think, I first thought about the idea that the people in my neighborhood don't know how to dispose of their rubbish. So if I could hire some guys in the neighborhood, then I could get them to, I wouldn't be the one to pick up the rubbish, but I could get people to do that. And I think people would pay for it. I thought it was a good idea. But I shelved it. I drafted it. I did a whole design of it. And then when I was 17, I thought about, why do we have to keep using our hands to weave kente? Why can't we get it? So I drew a machine back in the day that I thought could be of that.
Where is that coming from? That's my core question. Do you have am I bringing it? Was a father like that? Was a mom like that?
So I lived with my grandmother for my grandmother. She was.
This is interesting because there's a trend I'm picking up.
Okay.
Speaking to founders on this podcast,
right?
About 60% of them lived with their grandparents. It's an interesting dynamic.
Okay.
Is that most of these people were raised by their grandparents.
Yes. She raised me till I was, she had stroke when I was 13. And that was my biggest pain my whole life. I mean, because she was like, my God, my everything.
Yeah.
So when she fell sick, I was helpless. I was completely helpless, thinking about what to do. How do I help her? She had stroke, and I'd never seen somebody with stroke before, so it was quite a thing for me. But that woman was industrious. She was a nurse.
Okay.
A community nurse. She had a cattle farm. She had orange farm, tangerine farm, chicken farm, turkey farm.
Wait, in Accra?
No, we lived in Nsawam back then.
Okay.
She had all of that, and she was still a nurse, doing head nurse duties. You would never find her idle. Never. She was always, and I was with her almost, literally all the time. She's going here, she's coming here. Every Saturday we are going to one of the farms. And she owned these farms, and she had a lot of workers on all these places, all these farms. So I think.
You got that from her?
I think so.
And so I'm sure maybe after school, when you're working with Vodafone, a part of you felt like there was more you could do.
Yes.
And that's why you set out.
So I'll give you a shocker. Okay. I dropped out of school for 2 reasons.
Wait, university?
Yeah, I dropped out of school.
Which school?
Ghana Telecom.
Wow.
Yeah. I dropped out of school for the first reason was that I used to wonder what they were teaching. Oh, sorry. And so I started working before I went to school, actually. So instead of going to school as my colleagues were going to school, I went to get a job. I got a
After
job. So I
SHS.
started, yes. So I got a job with Vodafone before I went to school.
So you said why did you drop out of Ghana Telecom again? One was that you didn't understand what they were trying
Yes,
to
yes.
teach.
I used to wonder because what I knew in the real world didn't exist in the school. And I asked myself that if after this, what am I going to do? So I left Ghana Telecom and I signed up with NCC. IPMC had a program with University of Cambridge that was teaching business IT, which I found very interesting, and cybersecurity stuff. So I signed up with NCC, and it was great. I mean, I did a full 2 years. Then my shift at work, for some reason, was moved because I used to go for lectures in the afternoon. Then the school changed the lectures to morning. I have to be at work. So now I'm torn between work and school. So I had to drop the school. But in dropping the school, what I set out to do was then I'd have to be better than anybody. Everyone within that group. And when I left Vodafone and set up my company, I mean, 2 years later, I hired some of my friends from those schools, by the way.
Interesting.
So it proved to me that obviously, it's not that I don't believe in our education system. No, I mean, it works for some people. It's just not for some of us.
What do you think your core value is on that front? What value is a place in you that you didn't find in the school?
Problem solving.
Okay.
I didn't think what was being taught solved a problem. And perhaps if people want to, if it's some people's nature to work for some people for years till they die. I'm not the type.
Yeah.
When I was in Vodafone, by the third year I wanted to exit. My pastor wouldn't let me. He kept saying I should stay. So I stayed on for 2 more years. But I get bored with not just the monotony, but if I can't find progress, I need to make a move. I like progress. It excites me. So we have to make progress. In other words, what's the next thing? So we're doing something, but life evolves.
Yes.
So why are we not evolving into something? Why are we not building something new? Let's move on.
Okay.
So if we're not moving, then I have to make a change.
Yeah.
So
when you made the resolve to be better than any of the people in your group
Yeah.
at the time,
Yeah.
what did you do?
reading.
Okay.
I still do it, of course. I spent hours reading in a week, try and read about 15 books or more. Just read a lot. Because I realized that I was very limited in information. And if I met anybody who had just finished university with PhD or master's or whatever, I want to be able to look them in the eye and make them feel that they need me. Oh dear. How are you fetching this out of me?
It's good. It's good you mention the reading thing.
Yes.
Not long ago, a friend of mine wrote this on Medium about how the people who go on to do great things,
Mhm.
being great and subduing the world, so to speak, is a function of exposure.
Yes.
And exposure can come in the form of the people you talk to, how you were raised, traveling, reading, right? And so I think it's true. Like, it's true. Like, it's a mark of almost any person I speak to who's doing something remarkable. Is a certain contact with knowledge that most people don't know.
I think it's what I discovered from a psychology book I was reading was about the fact that, and being a Christian too, it became more real, that the brain is such that you have to push it to it's like a car with a lot of cylinders or valves. You need to really press that thing before some parts will open up. And it looked like our upbringing did not give us that energy to push our brains to solve problems or to think about what to do. Most of our people, even till now, still just wait for someone to give them something. Not how do I get it? Like, what do I do apart from asking? So for me, what pushed me in all these areas was not to be a laughing stock. You need to become something that can be reckoned with and say, this guy is good.
Yeah.
And good because you've really mastered what you are doing and you are open to learning on it every single second because there's something more.
Yeah.
And that's one of the things that drives me so much.
There is more.
Always. I mean, I remember when we launched ReFill during the MVP testing, someone very dear to me had what they call ischemic stroke. Of course, at the time we didn't know. She just went to work and I got a call that the person couldn't move. So they rushed her to the hospital. When I got there, I was just looking around. We had just launched the MVP, just about that. And it was confusing because I'm looking at this person and I'm looking at the situation. So the next morning, I started interacting with friends and family members who were coming around to check on her. And each person I spoke to had a chronic condition. I couldn't believe it. I had done my research. I had my research papers in my hand that indicated that at least 2 out of 4 Ghanaians have a chronic condition. And I thought it wasn't true. So here are 10 people in front of me who have come to visit someone. Everybody has some chronic, and some of them had been on medications for 15 years, 10 years. And I was like, yo, where are we going? So I called my friend. I said, bro, the data is true.
Yeah.
People are really, really, really struggling. And at that time, of course, I didn't know this person had a stroke. So we got to the hospital, and at UGMC, I was just going around asking questions, talking to doctors, talking to patients. And each person is like a zoo of problems. And everyone's main problem comes to one: medicine. After all the doctor does comes to medicine, and their pain is, where can I find it? How can I afford it? Where can I find it? So we go and we come back to it.
Wow.
But that became my use case that if we get this right, we'll be solving problems for millions of people. So expanded the research across 47 countries in Africa, and it's the same. Some are west. Ghana has we have about now you have almost every university in Ghana almost teaching pharmacology. So we are churning out more pharmacists than most African countries.
Okay.
On the flat. Some have one pharmacist to about 200,000 people. Some have to about 300,000 and all that. But when we looked at it on a large scale, you can see that the solution is clear, but there are no systems in certain places. So if you want to do anything outside of this country, then you have to now go back into a lot of some fine tunings. But with where we started off with the short code and so on, it became clear for us that, yeah, we can solve a problem.
Yeah.
But for me, driving back to the point about what you're asking me, it's problem solving.
Problem solving. So, in 2 years, you are in 14 of our, 15, more or less, out of our 16 regions.
Mm-hmm.
I know you're expanding to Tanzania. You're going to do Nigeria sometime in July or something.
Yeah.
That's like really a great scaling endeavor over a 2-year period.
Yeah.
And I gather that you've bootstrapped to this point. No external financing.
No.
How?
External financing. So my colleagues are also well experienced entrepreneurs in different. Most of us are all in IT. We are 4 founders. Myself, David, Kofi, and Mato. All of us are. David is a pharmacist, but the 3 of us are all in tech business in different areas. So experience is key, and from our years of experience, we're very clear on the fact that if we can solve the need to raise capital at the very early stage by proving that what we say we're doing is working and has the ability to scale and prove the scalability itself to you, to whoever wants to invest. If we've been able to go to Tanzania and set up shop and have traction, excuse me to say, without your money, when you come and you say you want to invest, you come at a high price.
Yeah.
Straight away. Because somebody has really worked to get that done.
Value.
We do the same for Nigeria. Now, over the years, we also built a network of friends who also have a need. So in some cases, almost like a barter trade. We have a ReFill platform. You have a health insurance company. We can partner with you, serve your patients in this country or that country.
Yeah.
So in Tanzania, we're going straight with one of our clients who's a health insurance company who have a business there, but they have a need for this solution that is working in Ghana. Since they partnered with us for us to serve their patients, their business has scaled like 6x. So
Yeah.
it's no brainer. Yeah, let's go here. They were even asking if we go to other countries in Pakistan. I was like, yo,
Calm down.
we want to work in Africa. So
Yeah.
the bootstrapping basically was to prove to ourselves first before we tell someone to bring their money to do business. And one of our biggest challenge even in that area was when we had to deal with a manufacturer like Roche for the first time. What they're looking for is cash intensive. It's not just a solution. They're a manufacturer. They are looking to do direct to patient. Not necessarily because they want to cut out the middleman. No, not necessarily that. But there's a lot of in-betweens that prevents the persons from getting their medication. And they have medications for cancer patients who are dying on the daily. They could give the person the medication at half the price. Like they actually can. So they wanted to run what they call patient support programs. That's where they wanted to bring the cost of medications down. Who will facilitate it? Who will give us credible data that the patient that we are about to serve actually can be served? This is their actual location. This is the doctor who served them. This is the dosage that they actually need month on month. And if they are taking these medications, how can we help measure? Who's going to provide us with a tool that will measure that for us? ReFill does that. We have that. They said, okay, why not? But along the line, they changed their mind. I mean, we figured out that they wanted something else. So they wrote back to us and said they will come back to that conversation because it looks like someone gave them an impression that we are a very big company. I don't know who did that. Yes, so but they offer commissions and it's like, oh, you guys are too big for this commission. If we have a bigger, we're like, yo, we are a very, very small team. No. Why? What you are saying you are doing is $1 billion solution. So why should we give you something that is for a few hundreds of patients?
I get it.
But that was just a twist. So we've been on with AstraZeneca and the rest. So hopefully this year we'll be marching strongly in some of these areas with them.
I know there's another health startup that comes to mind, M-Pharma.
Yeah.
Another great solution. How are you different from M-Pharma?
So M-Pharma's model, of course, they've pivoted many times, I would say. Started off as a digital pharmacy or digital health tool for people to get medications. They've moved on to working with brands. So first of all, we don't do brick and mortar. We don't own a pharmacy in the country. We work with every pharmacy, including M-Pharma. Pharmacies that they work with, as the multi-pharmacies. We don't have revenue share models with any pharmacy owner. We don't do brands because we are not tied to any brand. Okay. And most of all, we are not a pharmacy. So if a business is a pharmacy, that distinguishes us from them instantly. And M-Pharma is one. We work with organizations, healthcare providers that provide their telemedicine. Pharma does that. We work with organizations like that. Some of our clients are telemedicine clients who provide telemedicine for different people.
Okay.
So Pharma's multi-model that works for pharmacies, which we are not. So technically, our business with Pharma is that we give business to Pharma, they serve patients on our behalf as well.
Oh, okay. Okay. I see. So what have been the challenges you faced building this great company over the last 2 years?
Yeah. Well, biggest challenge for us has been the people, the culture of pharmacists. The education system trains pharmacists to become retailers. So they complete, now they do PharmD, as doctor of pharmacy. So they can either be clinical pharmacists or community pharmacists. Our initial intake of pharmacists were community pharmacists. Of course, we quickly switched to clinical pharmacists. But the training from school they have is to be able to go and work in the community shop of a pharmacy. And that is, excuse me to say, buy and sell. Basically, somebody wants medicine, they sell. So they don't have a corporate culture. How to work in a team. Where every pharmacist work in our setting, in the pharmacies where they work, they are the bosses. And they don't know how to manage a team, that's one. They don't know how to work in a team because they have MCAs and technicians, they give instructions to take stock and do this. So when we advertise for people to apply for our jobs, you get all kinds of pharmacists applying. And when you start talking to them, they start fidgeting. Why? They don't know how to talk to a patient. There's no empathy in their line of work. It's transactional. What we do is service. You need to have empathy. You need to be able to listen to a patient. And you need to be able to provide them with credible answers, not sell them medicine.
Yeah.
But if you walk into a pharmacy, if you've not had the experience yet, that would be great. But even me and some of my colleagues tell that, oh, no. If you walk into a pharmacy, you want to get medication, you will not be interacted with. The guy who's looking at you or the pharmacist who's looking at you, a few, 1, 2 places we've been to, you see the person smiling at you, trying to reason with you and understand what you're actually feeling. The rest is just, how much? Wait, where's your money? Okay, go here and give the money to the person and take your medicine. And there's no follow-up anyway. Nobody's going to follow up to check on you. We spoke to a few of the large chains and so on, and they said, oh yeah, they have data on patients. We said, okay, here's the system. Use it to manage your chronic patients. Oh, we are not sure. And we told them that the reason why you don't have that is that you don't have a patient control system. You don't engage patients.
Yeah.
You only sell to them. That's why you don't know who will come next. So people became our biggest problem, and that's pharmacists. So we have had a very, very high turnaround on that side, where you have many pharmacists who come through our system and say, oh no, I can't work here. Oh no, I cannot work here. So we picked some people from school. As we speak now, we are working, we're picking students from Central University and training them.
Okay.
Those are the interns we have, so that they get a certain working culture.
Okay.
Now, the reasons are very clear, apart from all that they learn in school and so forth. When you come into the real world of business, you need to be able to think and provide credible answers. If a patient is on the phone with you and is telling you that they have a back pain, you're a professional, but you're also a person. They are not trained in that area. So it's something that we are pitching in there. And that's because whoever sponsors the education material in town that goes to the universities only go to it's like what some people do for the nursing schools. They just want nurses to ship.
Mm-hmm.
So you have pharmacists who are coming out of school and don't know how to solve a problem. They don't know how to even do business. All they know is that I have a license, and because of my license, you should pay me X or Y. And you come into our world, we say, no, we don't. I don't need your license.
Yeah.
You need your license to work here.
Yeah.
I don't need your license for you to work here. If you don't have a license as a pharmacist, you cannot work here. So get your license and come. Now, when you come here, then we have to now train you. We have lots of SOPs and SLAs all over our systems. You have to go through rigorous training to be able to work in our system, in our business.
Yeah.
So that has been, for us, it's been the biggest.
Culture in people, creating a culture that fits
Yes.
the problem-solving value, which is the core value for you as a person.
Yes.
Interesting.
So those who have worked with us for the past year and have stayed on, they can tell you that, hey, this is the best place for us. We interviewed pharmacists, and you can hear them after school. They don't know what to do. They don't know where to go, because apart from working in their community pharmacy, or now some hospitals adopting the clinical pharmacy idea, even in the hospital where there are pharmacists, where they are supposed to be clinical pharmacists, there's not much to it for them.
Yeah.
Because they are not trained on patient engagement. So the guy is in the hospital as a pharmacist, but doesn't know how to talk to patients. He doesn't know how to engage a patient. Ideally, they should have been trained by nurses. Maybe that will help them.
The same way you were trained by a nurse, raised by a nurse.
Well, yeah.
Yeah.
And of course, anybody who's used our service, that's what they look out for. Someone who cares about their pain.
Okay.
That's all. Who cares?
Very interesting. So I see you're married.
Oh, yeah.
Yeah, waving your ring in my face.
Ah,
Yeah. You mentioned how long have you been married for?
13 years now.
And you are 38. So you married in like 24, 25?
Yeah.
That's very early.
Would have been earlier.
Why? What happened?
My father-in-law said, hey, you guys are too young. My wife at the time, we were friends. She was in the third year, Kiki University.
Wow.
Studying aerospace engineering. And it was like, oh, you guys are too young. You're too young. You just started out life. And I'm like, yo, I have a place. I got a job.
Let's do this.
Let's do this. And that old man won't let us be.
How has it been for you?
Pardon?
How has it been for you?
Has-
13 years.
It's been fun. It's been fun. It's nice to be with someone you like.
Yeah.
Yeah, that's the vibe. It's been fun.
Kids.
Too?
Great.
Yeah.
I'm happy for you.
Well, yeah.
And I wish you well with your business.
Thanks a lot, Bill.
Yeah. You know the funny thing about today's conversation, right? When Dick told me that you're going to do this at 8 a.m., I was like, God. Because I typically wouldn't, even if it's an 8 a.m. meeting
Yeah.
in my own business, I typically like to push it back a little.
I start my meetings at 10:30.
Yeah. So when they told me I have to be in this Accra traffic, this is going to be here, I almost wanted to incline them.
Yeah.
I was like, oh, can we push it back a little? Can we postpone? But I'm glad I came. You know, funny enough, it's this dynamic about how the best things happen after you just leave your comfort zone. And this is like one example of it for me. This conversation has been really impactful in many ways.
Now that you say it, I'm now wondering why I took an 8:30 call. Usually I don't.
Yeah.
I mean, I don't even, I'm up usually by 2 or 3 a.m.
Yeah.
I sleep at 12 or something, but you know how it is.
Yeah.
But I don't start business meetings
My mornings are
until
for
after
me.
9
Let
a.m.
me just reflect. Let me chill out.
Yeah.
Yeah.
I use my mornings to read and think.
Yes.
So it's still interesting. I need to
Yeah.
find out what
Right.
happened.
Thank you so much, Mr. Andrew.
Thank you so much, Bill.
Your company is on to do great things.
We aim to.
Yes. And the core value of problem solving was really stuck out for me, honestly. Because it's funny you mentioned this because you're about to introduce this thing to our community with
Yeah.
reading, you know.
Yeah.
And it's interesting that it comes out from this episode. So thank you so much.
I look forward to more episodes. I thought that this wouldn't happen, but
Here we are.
here we are, and
Right.
I'm grateful. Thank you so much for
Thank you
having
too.
me. And I wish you guys also all the best. I'm an addict of podcasts, so I
Yeah,
look forward to
this should be on the list as well now.
Yeah.
Right.
I was just listening to HBR on my way here. So
Oh, okay.
yeah,
How
I
about
do
business review?
all of it.
Great.
Idea casts, leadership, all of it. So
Good.
yeah.
All right. So, friends, community in Accra, the world beyond. I told you it was going to be a good conversation, and it's been a good conversation. So you know what the mantra is: just build something.
Yep.